Hello everyone and welcome to this lecture. The topic today is red and white lesions of the oral mucosa. So as I had mentioned in my previous lecture, as part of the oral diagnosis and surgical sciences, many of these lectures are going to be taken as joint lectures as we did in the previous lecture. Now this topic we are going to have 5 parts. So the first part of this lecture is going to be covered by me. All right. So the learning outcomes of this topic are: number one, by the end of this topic, you should be able to categorize the causes of red and white lesions in the oral cavity and differentiate them clinico-pathologically. Number two, you should be able to explain oral potentially malignant disorders or OPMD. Number three, you should be able to explain the etiopathogenesis, clinical features, histopathology, diagnostic workup, differential diagnosis, and management of the following. Number one, oral candidiasis. Two, leukoplakia. Three, lichen planus. Four, erythroplakia. Five, oral submucous fibrosis. And six, systemic lupus erythematosus. The fourth learning outcome is you should be able to illustrate the histopathology of various grades of epithelial dysplasia. And lastly, you should be able to identify the importance of the grades of epithelial dysplasia in a histopathological report and choose the appropriate treatment option. Right. So I'd like to mention here, guys, that these outcomes, now I will be dealing with some of these at the beginning of my in this part one, and some of them will be dealt further up by Dr. Larry and me collectively. So in these coming slides, you will notice that what I'm going to discuss is number one, the categories that cause the red white lesions. Okay, I'm going to explain the core concept of oral potentially malignant disorders, and I'm going to explain the histopathology of various grades of dysplasia. The part two of this lecture series, which will be covered by Dr. Hari and me, would include the learning outcome number three and subsequently the learning outcome number 5, which will also be dealt in the practical sessions as part of case-based learning. The first thing that I want you to reflect on is how do we see color, right? The reason I am asking you this question is because of the name of the topic. If you look at the topic name, it says red and white lesions of the oral cavity. So that means we're trying to categorize the presentation of certain lesions based on the color, right? So how do we see color? So just to recall something that you learned in optics as part of your physics, maybe in foundation or in early years, right? White light is composed of different wavelengths of light, right? Which when mixed together actually produces the white light, and this white light is composed of 7 different colors, right? So if there is a red color that we are able to visualize, okay, like for example this apple over here, it means that when this white light falls on this red apple, it actually absorbs all the other colors of the components of the white light but reflects only the red, and that's why we're able to see the red light. Okay, so this same laws of physics or optics actually apply to all the other colors as well. All right, so we're able to actually see black. Anything that is black, physically black, is because when light falls onto it, that particular object or that particular color actually absorbs all the wavelengths and there's nothing that is reflected black. Red, as we just discussed, and white is when we see the entire color of the light that is reflected black. Now this is very important because this is what is the physics behind how we see color. Now we will see how this also leads us as dental students, as dental surgeons, and as oral health practitioners to be able to categorize different colors of lesions that we actually see, mainly white and red lesions over here. Okay, question now is what factors affect the color of the mucosa. So number one is obviously vascularity. Okay, now here is a picture of a patient who had a lesion on the tongue. You can clearly see that this entire thing appears normal, and here there is a a bluish reddish lesion on the surface of the tongue. Okay, now the reason we are able to see this is because there is increased vascularity. So that means what I'm trying to make you understand here is that if this is the clinical appearance, if we would do a microscopic examination of this piece of tissue, what would we see? And what we see under the microscope, how does that relate to how the lesion appears clinically, right? So we're able to see a red and bluish appearing lesion on the tongue because microscopically there are large big blood vessels that have stagnant blood in them, right? So as we know, when there is stagnation of blood, there will be it will be composed of mainly deoxygenated blood, which appears bluish reddish in color, and that's why the reddish hue clinically that is visualized. Okay, so number one factor that affects the color of mucosa is vascularity. Second is melanin pigmentation, right? So we are familiar with the term oral melanotic macule, and if you look at this picture here, you're seeing a brownish pigmentation on the lower lip. If we actually do a biopsy of this particular piece of tissue, this is how it's going to look, and you can see that there is increased expression of melanin pigment in the basal layer, right, giving it the brownish color appearance. The third important reason why you see a change in color in the mucosa could be keratinization. Alright, so when we say keratinization, it appears as a whitish lesion on the mucosa, right? And this whitish lesion that you're seeing on the gingiva in this particular picture, if we correlate it with the biopsy that we do, then you will notice that there is this pink layer of keratin that is produced on the surface of the epithelium, giving it that additional thickness because of which the light cannot penetrate in and is entirely reflected back, right? So this is how we would actually apply the laws of optics here to be understand why we are able to see a white lesion, right? So here in this case, this lesion is white because of increased keratin that is produced on the surface. Right. Another reason for increased or for a lesion to appear white is because of the epithelial thickness. One reason of increase in epithelial thickness is because of overproduction of keratin on the surface of the epithelium, which I just mentioned is called hyperkeratosis. Another reason why when epithelial thickness actually increases is when there is epithelial hyperplasia. Okay, so you have to understand that epithelial hyperplasia is when the number of cells increase in the layers of the epithelium without production of keratin on the surface, right? So this is the difference between hyperkeratosis and epithelial hyperplasia. So in either condition, what is happening is that the white light is finding it difficult to penetrate in and thus is reflected out. Okay, so because the entire wavelength of light is white light is reflected back, we are able to see these clinical lesions as white lesions. Okay, right. So just to recall how normal epithelium looks, this is how it looks, right? So normal stratified squamous epithelium of the in the oral cavity, right? You're seeing these retipex, right? You're seeing the basal cells that are arranged, the spinous cell layer, the regular stratification here, and the surface layer. This is how it looks, right? Now to compare that to an atrophic epithelium. Now this is what is described as an atrophic epithelium. That means the thickness of the epithelium reduces, right? There is a loss of rete ridges, the thickness reduces, thereby increasing the amount of light that is able to penetrate through the epithelium and refract the underlying color of the connective tissue to us. Okay, so I want you to understand that a normal epithelium histologically will clinically appear like this, right? Whereas an atrophic epithelium, as described here, will actually give us a reddish lesion, right? That means the thinning out of the epithelial layer leads to the underlying connective tissue and contents of the connective tissue giving the reddish hue clinically. Okay, so with this background, you will be able to understand red and white lesions, uh, the reasons for why a particular lesion appears red, why a particular lesion appears white. Okay, and as we go along, you will be able to understand that what is the importance of these colors, okay, or these lesions in terms of us being able to predict the outcome, to be able to predict the prognosis of the disease. Okay. Right, so let's first look at the possible causes of keratosis. Okay, so histologically, I've tried to tell you that keratosis, if it's taking place, it means that there is an extra layer of keratin that has been produced on the surface of the epithelium, but there could be a lot of reasons for which this keratosis can take place. So I'm going to run you through this because this is important as part of the first learning outcome, which was to be able to categorize the causes of red and white lesions. So here we're going to look at the white lesions, causes of white lesions first, right? So number one is traumatic. Okay, so they could be trauma, mechanical trauma, okay, as in let's say a sharp denture, a sharp tooth, okay, which constantly causes irritation of the mucosa, giving rise to a response where there's production of keratin and it appearing white to us. Okay, the second reason could be chemical, for example, aspirin burn, all right, or number three could be thermal, right? For example, a pizza burn, okay, or any hot liquid that a patient actually has that causes trauma here, and this trauma actually leads to sloughing of the epithelium, thus increasing the thickness and thus making the lesion appear whitish. Okay, the second cause could be categorized as infective. Under that, you have candidiasis, which is a fungal infection. You have oral hairy leukoplakia, which is caused by Epstein-Barr virus, and you have syphilitic leukoplakia, which is caused by syphilis. Okay, a manifestation of syphilis. Under the hereditary causes, you have white sponge nevus, we have genodermatosis, a category of disorders collectively called genodermatosis. That means they are they're genetic disorders which are hereditary and they cause skin as well as oral lesions which appear white. And of course, leukoedema, right, which is again hereditary but is not a pathology and is categorized as a normal variant. The next is dermatological causes, for example, lichen planus, which is a condition that affects the skin as well as the oral mucosa, okay, in which there could be white lesions or red and white lesions in the oral cavity. Lupus erythematosus, another skin lesion which has oral manifestations wherein we could see keratosis. And of course, neoplastic, that means carcinoma in situ or squamous cell carcinoma, also present as white lesions or keratosis. And the last is idiopathic, which is called leukoplakia. Now I'm going to discuss leukoplakia a little more in detail further on in this lecture. Okay, but the aim of this slide is to make you understand that these are the various categories of causes for keratosis in the oral mucosa. Okay, now moving on to the concept of oral potentially malignant disorders. Now, first of all, I'd like you to pay attention here because this is a very important core concept. Okay, and there is a little historical background to it. Before 2005, okay, before 2005, um, many oral lesions were categorized as pre-malignant lesions or as pre-malignant conditions. Okay, but after 2005, the World Health Organization recommended a nomenclature wherein they clubbed both the pre-malignant lesions and the pre-malignant conditions together to be able to call them as oral potentially malignant disorders. Now, the reason why the WHO recommended this new nomenclature is because both pre-malignant lesions and conditions. Okay, first of all, what are pre-malignant lesions? Pre-malignant lesions are basically any lesions that some lesions that when present in the oral cavity have a high chance of turning into cancer. Okay, whereas pre-malignant conditions is a condition of the entire body of the person wherein his oral cavity is at a higher risk of developing malignancy. So what the WHO did is, instead of having these two categories, they actually merged them together to call them that if a person has any of these disorders, whether they are specific lesions or the overall condition of the body, then it is called oral potentially malignant disorder, or that means that this person has a high risk of developing oral cancer at some point. Okay, so this is very important, and the reason why I stress this is because if many of the textbooks still do not actually mention oral potentially malignant disorders and are still categorizing them as malignant and premalignant lesions and premalignant conditions. But we would want you to use the newer terminology and follow this up. I do understand this is already more than 10 years old, but unfortunately, this is how it is in some books. Lesions, oral potentially malignant disorders, that means have this chance of from normal to cancer. Okay, so that's what this whole thing is. Right, so let's look at leukoplakia here. So the most accepted definition currently is that is given by Tony Axel, who mentions that a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion. Right. So we have to pay attention to this point. That means first of all, leukoplakia is a white lesion on the oral mucosa. And most importantly, we come to the diagnosis of leukoplakia when we cannot characterize it as any other definable lesion. That means all the other causes, traumatic, infective, neoplastic, hereditary, okay, or dermatological. The previous slide there where I explained the various causes. So when it does not fit in any of those categories, that's when we call it leukoplakia. Now, leukoplakia has a dose response relationship with tobacco. It is commonly seen in tobacco users. The more you are using either smoked tobacco or smokeless tobacco, there's a high chance of developing leukoplakia. The demographics vary regionally. That means based on the habit of the patient in various parts of the world. There are different areas in the oral cavity that present with leukoplakia. Onset is usually after age 30 and the peak incidence is after 50 years. In the West, there's a female to male ratio of 1:1. In the East, there is a higher male precedence as compared to females. The etiology is multifactorial. Okay, so tobacco, as I told you, has a dose response relationship. Alcohol acts as an adjunct here. Candida albicans in many cases also causes hyperplasia and leads to a lesion called candidal leukoplakia. Okay, wherein there are hyperkeratotic lesions that are secondarily infected with candida, and sometimes the long-standing candidal infection can cause dysplastic changes as well. Viral agents such as HPV 16 and 18 are also considered to be an etiology. Nutritional deficiency and genetic role has also been identified. So as you notice, leukoplakia is multifactorial. Clinical classification of oral leukoplakia, just to make you aware of it a little more in detail, will be discussed again by Dr. Lari in part 4 or part 5 of this lecture. Broadly, it's classified as homogeneous leukoplakias and non-homogeneous leukoplakias. So this word homogeneous is related to the color. So when the color is uniform and white, then they call it homogeneous leukoplakia. If the color is not entirely white but has patches of maybe red or normal looking mucosa in between, then it's called non-homogeneous leukoplakia. Okay, so these are the various 4 categories under homogeneous. So you have flat, corrugated, wrinkled and pumice-like, all descriptive terms. Non-homogeneous leukoplakia, you have verrucous leukoplakia, nodular, ulcerated and erythroleukoplakia. So this is an example of a white patch that is seen on the floor of the mouth. If you look at it, it's very uniform. The entire white color, the color is white everywhere, and so that's why this is homogeneous leukoplakia. Has come to us. We know the background that it's related to tobacco use. We know that this is and could be an oral potentially malignant disorder because we've come up with the diagnosis of leukoplakia. We know that oral potentially malignant disorders have a high chance of developing squamous cell carcinoma or oral cancer. So what are we going to do? We're actually going to do a biopsy. The reason we do a biopsy is to be able to identify cancerous changes early. Okay, the success for us as oral healthcare providers is not to be able to identify overtly looking cancerous lesions, but to be able to identify early lesions, right? Early changes, so that we catch it early, treat it early, and ensure that the prognosis is good. Okay, so with that, what we are trying to look at in these biopsies of these leukoplakias or oral potential malignant disorders is these set of epithelial dysplastic features. Now I clearly know that in second year you are familiar with this, but we're going to go through these in detail. Okay, because this is the core concept of oral potentially malignant disorders, right? So before I take you further, I'm going to again reinforce. So I've explained to you what is why a lesion looks white, why a lesion looks red, which of them is dangerous, the reason why that is dangerous, and the list of what is oral potentially malignant disorders. An example that we are discussing right now is leukoplakia. Now, leukoplakias can be homogeneous or non-homogeneous, right? Now we're just saying that now let's say we have a patient who's come to us who has leukoplakia, and we want to actually identify what is going on microscopically, right? So we are actually, what are we worried about when we are trying to do a microscopic diagnosis? What we're worried about is, has the patient mucosa undergone any cancerous changes? So when we say cancerous changes, we mean epithelial dysplasia. Okay, right. Now epithelial dysplasia, we have these 13 features that are outlined by the WHO that helps pathologists and oral pathologists identify epithelial dysplasia. So number one is loss of polarity of basal cell. Number two is basilar hyperplasia. Number three is increased nuclear cytoplasmic ratio. Number four is drop-shaped retipex, increased nuclear number of mitotic figures, individual cell keratinization, irregular stratification, cellular pleomorphism, nuclear pleomorphism, prominent nucleoli, loss of cellular cohesion, and abnormal mitosis. Okay, so in the coming slides I am going to explain each and every feature individually so that you can actually understand them. Right. So the first one is loss of polarity of basal cells. So what does that mean? So this means that when basal cells are not arranged perpendicular to the basement membrane. Okay. Now, if you look at your diagrams, or if you remember how you had actually drawn normal epithelium, it was basically you had a line here, you draw the regular retipex like this, right? And then in the retipex you actually draw these basal cells like this, right? I'm sorry, I think we've gone wrong here. So let me try again. Let's say this is a basal cell. What you do is you actually draw the nuclei around here, and you make sure that this base is the basement membrane, while this is the basal cell. Now if this cell loses its orientation to the basement membrane, that means it loses its alignment, then you call it loss of polarity. Now this is what this particular area clearly shows you. Okay, this is you see this is the entire loss of polarity. Second is the cells are not arranged perpendicular to the basement membrane. Now this is normal epithelium, right, which I have shown you in my previous slides as well. This is the retipex here. These are the basal cells. Basal cells usually are the first layer. Okay, are usually the first layer above the basement membrane, and they have the progenitor cells which actually mature and progress to become spinous cells, so on and so forth. So the layers of the superficial epithelium, and then they exfoliate, right? So that's the normal life cycle of an epithelial cell. Now what happens when there is basilar hyperplasia is you see two layers of basal cells. And how do you identify them? You identify them based on their dark hypochromatic nuclei, right? So now if you see a double layer of basal cells, well, that is not good news. It indicates activity in the basal cells, okay, which means that something that's wrong. Okay, indicative of a dysplastic feature. The next dysplastic feature is drop-shaped retipex. So what do you mean by drop-shaped retipex? Well, if you notice, this is the shape of the retipex now has transformed to look like a drop, right, like a water droplet. Okay, again, this is taking place because of the rapid proliferation of cells, which is leading to. If you look carefully, the other features are pleomorphic cells. Pleomorphic cells, the term pleomorphism is, pleo means many, morph means morphological appearance. If you look at these cells here, different cells have different sizes and shapes, okay, which increase, which is seen, which is described as pleomorphism and is a feature of dysplasia, right? This picture here also shows you cells where there is mitosis, and these mitoses are not normal. The reason why this is not normal is this is one cell which is showing a tripolar arrangement of the nuclear material, indicating that this one cell is going to divide into three. Okay, another feature that you notice here is that this is the nuclei. Inside the nuclei you are seeing two nucleoli. Okay, so that is prominent nucleoli. This is another cell over here which you're seeing is undergoing mitosis. Okay, but this mitosis looks like normal, but this is abnormal mitosis. Okay, so all of these are features of dysplasia that can be under the microscope. Okay, so again, mitotic figures, right? You're seeing the chromatin material that's arranged over there, and this is a feature called individual cell keratinization. So if you look at this, when this epithelial cell is showing increased pink color material being deposited, then that is indicative of keratinization that is taking place. So now we have normal epithelium, which is regular arrangement, right? Regular stratification. But in dysplasia, what happens is there is a loss of stratification. That means there is irregular arrangement of these cells as they mature and progress further, which is not good news. Okay, which is indicative of dysplasia, which is indicative of a pre-malignant change, right? That means this part of the epithelium has a higher chance now of going into, right? So epithelial dysplasia reflects abnormality in proliferation, in maturation, and in differentiation, right? So epithelial dysplasia reflects these three abnormalities. Now, once we see these features in the epithelium, we are required to actually again grade it. Okay, it's not just enough to identify these features; it's also important to be able to grade them. So when to grade them, basically, what we do is we actually divide the epithelium into three equal parts, okay, to try and see into which area, into which part you are seeing these features. Okay, so if you are seeing dysplastic features just only in the lower one third, then this is mild. Okay, but if you are seeing in lower one third and the middle one third, then you call it moderate epithelial dysplasia. But if you are seeing dysplastic features entirely in the thickness of the epithelium, then it's anywhere between severe to carcinoma to convey to the clinician so the importance of what exactly is happening, right? So again, I would like to tell you that when you grade epithelial dysplasia, when we see epithelial dysplastic features, we grade them. Okay, now according to the WHO, we can grade them as mild, moderate, and severe. There's another new system that is actually becoming more accepted, which is called the binary system. Okay, wherein you just grade them as low grade dysplasia or high grade dysplasia. So what's happening is mild epithelial dysplasia is considered to be low grade, but moderate, severe, and carcinoma in situ is together being graded as high grade dysplasia. So the reason this change from a 3 grades to a 2 grade two grade system is for easy communication with the clinician and to be able to communicate to the patient so that regular follow-up treatment and prognosis can be better. Okay, so the important point here is, now if we have a patient who is identified as having leukoplakia, which is an oral potentially malignant disorder. First of all, leukoplakia is a term we use as a clinical diagnosis of exclusion. Okay, that means you come to this diagnosis only if you have not been able to categorize it as any other known white lesion. Secondly, microscopically, a leukoplakia could be anything between hyperkeratosis, epithelial dysplasia, or squamous cell carcinoma, right? So the spectrum of a leukoplakia, a clinically appearing lesion which is called leukoplakia, could be anything between a banal hyperkeratosis or epithelial dysplasia, any of these grades, okay, or worse situation would be squamous cell carcinoma, right? So what I'm trying to explain to you here is a white lesion or a white and red appearing leukoplakia here could be either hyperkeratosis, epithelial dysplasia, or squamous cell carcinoma. So, okay, we have the clinical diagnosis. We've looked through the microscopic diagnosis. So, what about prognosis? What are we supposed to tell these patients? So, well, a proportion of these dysplastic lesions will undergo malignant transformation. It varies anywhere between 1 year to several years, and dysplastic lesions carry increased risk of malignant transformation based on their grade. I'll tell you that. Malignant transformation is likely due to progressive accumulation of genetic changes over time. Right? So, based on the histopathological grading, mild dysplasias have good prognosis. That means uh, there is a very high chance of, if the patient stops the habit at this point, then the lesion can reverse, and the patient has less risk of developing oral cancer, whereas moderate and severe epithelial dysplasia, they have fair and poor prognosis because the genetic changes, genetic damage that has taken place because of the exposure to carcinogens is more than that in mild dysplasia, and there is a fair risk of the patient developing cancer. To give you a perspective, in Malaysia, the prevalence of oral cancer is very high among ethnic Indians, followed by Malays and then Chinese. The occurrence of oral potentially malignant disorders again is high in ethnic Indians, followed by indigenous populations of Sabah and Sarawak. Now, according to the National Cancer Registry, mouth cancer can be ranked as the seventh and the third most common cancer for the ethnic Indian males and females respectively. Oral cancer is the second leading cause of death due to cancers among Malaysian males in Malaysia, according to the Ministry of Health. Okay, and the risk habits in Malaysia for patients who develop oral cancer is: number one, the highest is beet liquid chewing, which is seen in 59.9% of the patients, followed by smoking 36.1% and alcohol consumption 35.2%. The most common site where oral potentially malignant disorders or precursor of cancers can be seen in Malaysia is has been identified as buccal mucosa, 36.2%, followed by tobacco, followed by tongue, 33.8%, gingiva, 21.5%, the palate, 4.6%, and the floor of the mouth, 3.8%. Okay, so with this in introduction to the red and white lesion, I hope you have understood the concept of why the mucosa appears red or white, the different reasons for a white appearing lesion in the mucosa, what is the concept of oral potentially malignant disorder, why is it so important, what would it look like microscopically when we biopsy oral potentially malignant disorders such as leukoplakia, which is quite common, because and what would be the how is it microscopically identified, how is it graded, how is dysplasia graded, and how does that affect prognosis. Okay, so this is the aim of this lecture. I hope you have understood it. We will again rediscuss some of this as case-based learning when we look at the practical session that will be done on Google Classroom. All right, so thank you very much. Have a nice day.